All right, let's go to cardiology. Why is cardiology important? Well, our heart's important. We don't live too long without them, right? The total cost of heart failure in the United States is expected to be $70 billion by 2030. Now, if you notice in these lectures, I use a lot of words on cost. Why am I going to use cost? Because medicine is expensive. We are paying too much. The system is costing too much. It's costing the federal government too much. It's becoming a crisis. So you're going to see that the boards are geared towards cheaper. Your systems, both your inpatient and outpatient systems, are going to be geared toward using cheaper solutions, cheaper, better solutions. That's what we're looking for. Physically touching the patient, so that way maybe you can avoid some imaging by you actually putting that thing called the stethoscope on their chest, bring it into the room. It's not good in your car hanging on the dashboard so that way you look cool when you're driving down the road. You need it in your hands on the patient. So estimated in the United States almost about 700,000 people die in heart attacks each year. And then heart disease is responsible for 1 in 5 deaths in the US annually. Wow, isn't that crazy? You want to do a quick cardiology joke? Why not? We can make fun of the cardiologists. They make a lot of money, so they can do. Why did the cardiologists bring the ladder to the party? Because they heard they were going to be the toast, and they wanted to make sure they were taller than everyone else at the time to raise them glass to themselves. So they heard there's going to be a toast, and the cardiologists wanted to be toast them to themselves, and they want to be taller than everybody else. Simple cardiology joke. All right, perfusion. This is the key. Everything we talk about in all the disciplines is about perfusion. We have to get gas to the brain. We have to get gas to the kidneys, to the liver. We have to get gas to these organs. Just like your computer or your car doesn't run without the juice, our brain doesn't run. So remember, perfusion is king. So if we don't have perfusion, it's bye-bye, okay? It's bye-bye. We're done. So perfusion, adequate blood flow of oxygen and delivery to the organs. Signs of poor perfusion, mental status changes. You're not getting flow up here, just like your computer. If it doesn't get proper power, it doesn't work well. Chest pain, you're not getting proper perfusion to the coronary artery system. Shortness of breath, your heart isn't able to squeeze and fluid builds up in your lungs. Decreased urine output, because guess what? The kidneys get about 25% of our blood flow from our heart, and they're very finicky. If they have huge amounts of ATP being used and they have huge amounts of sodium potassium pumps that require a lot of energy, and when they don't get that energy, they do what? They stop peeing. They stop working. They're like you. They stop working when you get mad, right? They're mad, they stop working. All right, let's go to a simple one first. 51-year-old male, past medical history of hypertension, hyperlipidemia, and diabetes mellitus. So he has 3 horsemen of the apocalypse right there. Hypertension, hyperlipidemia, diabetes mellitus. This is what's killing us, is these 3 horsemen is what's taking out our population. If there was invaders coming in and people would be fighting in the streets, if these were people, these hypertension, hyperlipidemia, and diabetes mellitus, because they're destroying our population. Complaints of chest pain. So is he probably not perfusing? Now, what are the things we want to ask? We want to get these, you want to get these in, and it's to make your assessment of the plan complete. History, when did the pain start? Location, we're going to do 5 of these, right? Location, where is the pain? What is the intensity on a scale of 1 to 10? How long do you have the pain? What makes the pain better or worse? Remember, these are the 5 things, the 5 factors that we need to do to get it together to kind of work on our patients. Now, what are some risk factors? We talked about these: hypertension, hyperlipidemia, diabetes mellitus, smoking, and then what else? Family history. Now, if somebody, when you're doing your physical exam and you say, hey, I have chest pain here, and you touch there, and they have pain there, and they said, well, I was doing kickboxing just yesterday, and now I have this pain there. Now, do they have a higher probability of having a heart attack? No, but they have a lower probability, because if there's chest wall tenderness, they have a sensitivity of 92% of this not being a heart attack. So there's still 8%. So what's the highest pool positive likelihood ratio? We'll talk about likelihood ratios. The highest is sweating. So if somebody's diaphoretic on exam, now you have to remember is that not everybody presents as chest pain when they come in for any type of lesion in their heart. It can be a toothache. There's been presenting complaints of toothaches as for heart attacks. And there's been cases where patients have had full MIs and never had any pain. They'll have some shortness of breath. There's case reports of people with MIs that have never had pain. This is a drawing. The reason why we have this is I want you to start thinking of your EKG instead of that flat piece of paper that the tech or the nurse or whoever does them in your system does and hands it to you. This is a living document, and this is showing our heart. This is recording the heart's electrical activity through the cycle. The electrodes are placed on the skin. The electrodes detect the small amount of electrical changes as a consequence of cardiac muscle depolarization and repolarization. That's what you're seeing in those squiggly lines. And then these leads are placed, and it's to give us a three-dimensional picture of the heart on a sheet of paper. This is just kind of to get you a picture of what's going on in the EKG, is to kind of see is if these areas have a issue or an ST elevation, what type of things can be going on? Is this septal? Is this anterior? Is this lateral? Is this inferior? Just taking a look at these can help us understand where the lesion can be. Now, you have to think about how crazy this was. EKGs were invented in 1902 by a Dutch physiologist, Wilhelm Einthoven. He developed the first practical device to record electrical activity of the heart. And it was literally using strings to kind of measure. And then the first clinical EKG was recorded in 1905 in the Netherlands, in Leiden University. So look how far we've gone with this information. Now look at this guy. What is going on here? What is going on? We have some ST elevation right here. I'm going to circle this. Look at that. ST elevation. And we'll talk about why there's ST elevation. And this one happens to be what? An LAD. This is a STEMI. Okay. So what are we looking at as LAD is ST segment elevation in two or more contiguous leads, indicating a complete heart block of the coronary arteries and significant heart muscle damage. The criteria differ, but it depends on the age and sex, but mainly is we want to have in two contiguous leads, and we want to have it generally is 2 millimeters or more, two little dots or more, two little lines or more in men. It can be 1.5 in women. Usually you can even do it as 1 millimeter if it's pronounced. And then you want to have the reciprocal changes as ST depression in the opposite area of infarction is seen in further evidence of a STEMI. So ST depression kind of over here. ST depression. So when you're doing EKGs, if you really think, I really feel like this patient is having a heart attack, we do serial EKGs so that way we can catch it. So the EKGs can evolve over time. All right, now let's talk about ST depression or ST elevation, okay? Which really is what, and we'll talk about this better, is that ischemic changes decrease ADP production. And this changes our potassium export, because remember, they have increased potassium export is through the sodium potassium channel. So decreased ADP production, changes in potassium export. You have increased potassium export through the potassium ATP channel. This increases potassium export, leads to faster depolarization of the ischemic tissue, creating a current between ischemia and non-ischemic myocardium. So actually the current is directed away from the EKG leads, resulting in a lower baseline. So instead of ST elevation, we have a lower baseline on the EKG tracing. Now this is a crazy thing, is we're going to talk about physical exams. Okay, I know that people don't want to do physical exams. You'd rather have a drone fly in a room or take a picture of the patient or have the nurse take a picture of the patient or have the janitor take a picture of the patient than you going in a room, because patients smell. They smell, they talk to you, they do all these annoying things. They'll ask you questions. But we have to go in a room. We have to touch our patients, okay? And I want you to remember this, and this is a simple mnemonic for taking care of the patients. Look at our chest wall and look at this right here. All patients take medicine. Aortic valve, pulmonary valve, tricuspid valve, mitral valve. All patients take medicines. So right here, aortic valve, second right intercostal space, right sternal border. Pulmonary valve, second left intercostal space, left sternal border. Tricuspid valve, fourth left intercostal space, left sternal border, and then, I'm sorry, pointing wrong side on me. I'm not lost my mind. Here it is. Mitral, tricuspid valve, and then going to our mitral valve. So then we have an idea where the valves are, and then we'll talk about it. Now, in doing a physical exam, you're supposed to do what first? Palpate, 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 palpate. We'll talk about why that's important. While you're palpating, you can see if they have costochondrital tenderness. Remember, we talked about it. That would lead that they'd have a lower preponderance, a lower risk of having a heart attack. They still could have one. You can have costochondrital tenderness and having a heart attack at the same time. Doesn't mean you stop working on them, but you have a lower suspicion, lower pretest probability. All right, now we're talking about heart murmurs. This is where you actually have to have your stethoscope, and you have to put it on their body, Okay, we're going to talk about the intensity. This is how we talk to other providers so we can say what the murmur is. First, we want to know the location, and we want to know where in a cycle it's going to be. Is this going to be systolic or diastolic? Or is it going to be through both cycles? Whole systolic is where you have them through both cycles. So how can you know? What's a quick trick? You can have your stethoscope, you actually have to put it on their body, and then you feel the pulse while you're doing it. So you have the stethoscope and you feel the pulse. So if you hear the murmur at the same time as the pulse, it's systolic usually, okay? And you want to feel, is there a long time from when you hear the murmur to when the pulse is felt? That could be no more information. So we graded by intensity. There's a 6-point scale. Grade 1 is very faint. Grade 2 is quiet but heard immediately. Grade 3, these are probably more you're going to see of these. Is grade 3 is moderately loud. Grade 4 is loud, like you put that stethoscope on and you're like, man, I don't even need to move it, and there's one. Grade 5 is heard with the stethoscope partly off the chest, like you don't even have to put it down. Grade 6, you can hear it in the cafeteria where you're eating your Cheetos, okay? This is one everybody can hear this, okay? Now, remember we talked about palpation? Palpation, 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 okay? So if you can feel a murmur, it's called a thrill, okay? So what's important? If you can feel a murmur, it's a thrill, and guess what? It's already automatically a grade 4 or greater. Grade 4 or greater. You got your thrills, okay? 4 or greater, 4 or greater. I got my thrills, I can feel 4 or more. All right, now we're gonna talk about the statement. And this is true but not true. Coronary angiogram only detects 5% of the coronary artery. It's somewhat misleading statement is it gets the main vessels. It gets those big vessels that we need. It may list some of the late stage plaque and difficult, little complex features, but it mainly gets there. And what's going on with the coronary angiography? So basically, in most cases, most of the interventional cardiologists, they want to go through the radial vessel, okay? Radial vessel, okay? You also can go through the femoral if needed, but the main goal is to go through the radial as much as possible. And what they do is they stick a catheter. What's a catheter? It's just a tube, a hollow tube, and we're just going to put it up there into the heart. It's pretty crazy when you think about it. And we're using it, we're going to shoot dye into there, and we're going to look at the structure. We have a picture of that, so we can look at the structure of the heart. Now, standard angiogram can underestimate or overestimate narrowing. So we're going to talk about that, but we're going to talk about tests that can be done to mitigate that. And why do you need to know this? So you can correspond with your patients, correspond with other providers. The limitation in angiography is why other techniques, and we'll talk about these, fractional flow reserve, which is used to assess the physiological impact of narrowing of the blood flow, we are using to determine the functional significance of the stenosis. It kind of gives us data on this, what we're seeing. Also can use intravascular ultrasound to evaluate the lesions, and we'll talk about these. There's also an optical coherence topography, which uses light waves to capture detailed cross-sectional images of the tissue. What we're looking for is vulnerable versus stable plaques. Vulnerable plaques we have to worry about is they can rupture. And even though you've had this coronary angiogram, you've gone through and everything says they're good, is back in the past, before we did these other tests, people go home and they're like, oh, you're great, your heart's great, and then they have a heart attack and die. So this is what we're trying to do, is to avoid this. So vulnerable are thin fibrous caps. So you think about, this is your cross section, this is your vessel, and then you're gonna have an area in here, it's a cap with bulging outward of the artery wall with large lipid core. And these can break, more prone to rupture, but there could be when you're looking at it, you can't see that the lumen's narrow. You can have a stable, thick fibrous cap going inward into the artery, which is less prone to rupture. But even those, if they get thick enough, they can push on and cause vessel damage. All right, this is what we're looking at right here. This is our coronary angiogram. So this is where they stuck, and they stuck the catheter in there, they went up in there and they shot the dye, okay? And we're gonna look right here, as you can see, as a stent was placed. So before the stent was placed, you couldn't see this area. So when they shot the dye through, there was a blockage and you could not see this area right here, okay? You could not see this area. In coronary artery disease, stents are used to open up narrow or blocked arteries and improve blood flow in the muscle of the heart, reducing symptoms like chest pain and a risk of a heart attack. That is why we have to do this faster. That's why there's these standards, the door to balloon time, and that's why hospitals are measured, systems are measured, providers are measured, is that how fast from when this patient hits the door and they're having an MI to how fast we can get the balloon and open up these areas of stenosis. So then a stent is placed, and we'll talk about there's different types of stent. A stent is a small expandable mesh tube, and these are very sophisticated. There's a lot of research and a lot of data on these. This is inserted into the artery via the catheter during angioplasty, and this is a procedure where they put the stent in and then they open it up with a balloon, and it pushes against the walls of the artery and it stabilizes. And the most important thing is it opens up flow. So I want you to think about it is that you can have all the money in the world, but if you cannot get to the store to purchase, say the internet doesn't work or your internet connection is there, you can have all the money in the world, but if you can't get there, you can't purchase items. Just like you can have the best of everything, best heart in the world, but if it doesn't get blood flow, it's going to break. Now we're going to talk about aspirin, which is a COX-1 inhibitor. And this was found over 3,000 years ago by Egyptians. They used to chew the willow bark and it helped them with pain. And it was synthesized back in 1897 by Felix Hoffman at Bayer. And Bayer still makes aspirin, and that's where the origination of this company is, the origin of this country. This is the origin story. Traced back to ancient times when willow bark was chewed for pain relief. Now specifically, there was a trial called the ISIS-2 trial demonstrated 25 to 30% reduction in 28-day cardiovascular mortality when aspirin was given within 4 hours of symptoms onset. This is back in May 1998. Aspirin, cheap. You can buy a whole bucket of it for $5, right? Preventing 25 to 30% of mortality. When we talk about cardiology, we're talking about MACE, major adverse cardiac events. And this is what can be avoided. This patient can live by a stupid 2-cent aspirin, okay? How does aspirin work? It inhibits the platelet aggregation or blood clotting in the arteries of the heart, promoting and restoring blood flow. And we're going to talk about primary and secondary, okay? So primary and secondary. What's primary? And I'm going to say it a couple times. Primary is before a heart attack occurs. So we're taking aspirin before a heart attack occurs. Secondary is they've had a heart attack, now the provider is recommending to take it. Heart attack, taking it, secondary. So what does it do? What are the side effects of this? You can have increased bleeding risk. So let's talk about our side effects right here. Contraindications, active bleeding. If it's active GI bleeding, you may even consider giving it if they're worried about them dying of a heart attack. Hypersensitivity, and we'll talk about this. Severe hepatic failure. So remember, our liver does so many things. It does about 300 things. We can only live a few hours without it working, and it creates coagulation factors. It helps us with clotting. So if you give this to patients with hepatic failure, you're going to increase the bleeding risk, okay, because of the clotting factor is already not doing well. You can further damage the liver. Aspirin can exacerbate liver damage, particularly in cases of acute liver failure or chronic liver disease. It can interfere with the myocardial function, leading to lactic acidosis and microvascular stenosis and hepatic dysfunction. Can also, in some cases, cause hepatic encephalopathy, has been linked in worsening cases of hepatic encephalopathy. Things to know. But if someone's having a heart attack, sometimes you're just going to have to give the medication and work through the rest. Now, there's a product called enteric-coated aspirin, and it's been proven a long time ago, but it's still on the market in 2013. And there was a study about drug resistance is pseudo-resistant, an unintended consequence of enteric-coated aspirin. Now, the gimmick was with the enteric-coated aspirin, as we all know that aspirin can cause upset stomach and it causes increased risk of a GI bleed. So with this enteric-coated aspirin, the theory was that's not going to digest in the stomach, less risk for GI bleed, less risk for problems. It didn't really work out as well. Is not as effective mechanism against GI production. And it's high, so it may not break down in the stomach, but you're still going to get it in the body, and it's associated with small bowel injury, so that the coating does not reduce the risk of GI complications. There's variable absorption. So there could be a whole bunch of people in a room, and one person gets enteric-coated aspirin and really doesn't absorb with it, the other does. So it's variable absorption, so you're taking a medication that can cause harm, but it may not work. And it doesn't work, so there could be a single dose of enteric aspirin, up to 49% of it cannot be absorbed, versus immediate release aspirin will be absorbed. 100% of it will be absorbed. All right, let's go through a question right here, and we're gonna walk through this question. And these are questions, and we're kind of go through while we're doing questions, but we're also gonna kind of look at how to attack questions for doing your boards. Because the whole purpose of you here is first to take care of patients, and to learn this trade or craft of medicine, but also you need to pass boards. And why do we do boards? We do boards is because how do we get to know that you've learned what you've learned? And this is where you get these test questions for. And are they fair? No. You're gonna get questions that are not fair. And some of these questions I'm gonna give you, I'm purposely giving to you, they're not fair at all. It's what the board has determined that they want you to learn.